We have in our midst Dr. Vikas Ranjan Ray, Critical Care at AIMS Delhi. And we welcome you to the Natco Pharma Specialty Studio this evening. We look forward to listening to you talking to us on the space of critical care, especially associated with bacterial resistance. What, as per you, Dr. Ray, have you seen the changes that have taken place in critical care management?
Uh, Thank you, first of all. Thank you, Natu, for giving this opportunity to discuss my views regarding changes in critical care. So it's a ever-ending, it's a ever-changing subject. Each day you have something new to look after, and you don't. There is nothing like this is the correct one. Whichever things is correct today, maybe tomorrow that is not the correct thing what you are learning. So it is always better to be evolving and to accept that whatever science is coming out may change in future. Another important thing is that critical care is basically taking care of the patient who is critically ill. Most of the time, it has the impression that this involves a fancy ICU with a lot of beds, with the fancy equipments. It does not like that. It can start from the periphery where when a sick patient comes, you give the basic critical care support so that the patient can be transported to a higher care if required. So those things has to be taken care. Although in our country, most of the time, the critical care, if you say, is limited to larger cities and town, it has to reach the peripheries, in my opinion. Then only you can have a effective outcome in all aspect of the patient management.
Uh, what is your message to the current set of doctors in the ICU, and how can they enhance patient care?
So my advice will be that I always believe that you should make the place or make the ICU where you are working a place, and if required in future, you yourself or your near and dear ones can be admitted, and you can confidently say that this is the ICU which has a very good practice, which has a protocol for everything, which has a very good antibiotic steerships, and that I can confidently advise anyone, even required myself or my near and dear ones, to get admitted in the ICU if required. So you always work towards the excellence, and in which workplace you work so that that can be achieved. And if required, you can take the benefit of that place also.
Great. What is the prevalence of carbapenems producing bacteria in your practice, and and the methods of treatment?
So actually, I work in a tertiary care hospital. So what we get patients is what our scenario is different from the other scenarios I suspect, because we have a lot of patients from different hospitals or in transferred from other settings. So the chances of bacterial resistance, antibiotic resistance are very high. We get a very less number of patients who are directly from the community. So in our setting, the carbapenem resistance is really high. And although since maybe last one decade, the carbapenems has been the first line of treatment when you start empirically. But now we have a different profile. Mostly we think post-COVID, we are seeing a different profile of organisms and antibiotic resistance in our setup. Uh, and how to approach them is maybe difficult in our scenario, but day by day, we are having a much more resistance pattern. And what I will suggest that it should be the antibiotic stewardship should be strongly implemented in all the settings, so that whatever patient we are getting in our should have at least a basic profile of what are the antibiogram has been used. And also, I like that if the antibiotic resistance does not start from, it should be start from basic level. Everybody should be aware of the antibiotic resistance, the basic hand hygienes, basic cleanings from the sweeper to the physician. Everybody should be aware of, so that we have a lesser resistance and you have something to use if you have resistant bacteria.
Great. Dr. Ray, thank you so much for being here, and we wish you all the best. Thank you for your valuable time.